welcome to my series of conversations with men and women whose ideas, vision and philosophy define our contemporary world. My guest today has had a distinguished career in medicine and has emerged as a philosopher of medicine. He was a Rhodes Scholar who studied and did his PhD looking at the role and function of hormones. He's currently a emeritus professor at the National Institute of Immunology. He heads the Scientific Advisory Board on the traditional medicine and has campaigned vigorously for the rational use of drugs. I'm delighted to welcome Professor Ranjit Roy Chaudhury. You started, much of your work was in classical allopathic Western medicine. And what prompted this interest in traditional medicine?
Well, I started my work in very classical and traditional Western medicine, and I did research on a hormone called oxytocin. From there, I went on to study reproductive endocrinology, and we were trying to find a contraceptive. At that time, I got interested in herbs which are reputed to have contraceptive effect. And we received a lead from Israel. In fact, the first one came. And then I looked at the Indian scene, and lo and behold, they said there are over 50 plants which have anti-fertility activity.
Ordinarily there's a great deal of sort of resistance, almost contempt that modern allopathic medicine has towards traditional medicine. What is the sort of the validation that you, as someone trained at the pinnacle of Western medicine at Oxford, found for traditional medicine?
Well, we have always been aware that traditional medicine has reported cures. Western trained physicians, like myself, don't accept this unless they are rigid, standard, controlled trials. And this is what I have attempted to do for the last 15 years, to bring these herbal remedies that are supposed to act into this structured, uniformed clinical evaluation.
To what degree of success and what reassurances can you offer to the average viewer? There is a great deal of interest in traditional medicine, and most of us turn to it at some time or the other, it's often confusing.
I would say that for simple treatment of simple diseases, cough, backache, headache, if you know which herbal medicines to take, these do act. But we have not got evidence of good clinical trials for major diseases like diabetes, cancer, arthritis.
But even for the sort of the everyday diseases that you're talking about, there is a sort of huge difference between the classic traditional medicine of going and using neem or using muletti or herb, and the packaged formulated drugs that are now sold and promoted.
Well, the situation is a little different now from the last 10 years. And this is largely due to work, not of our work, but of the work done in China, where they have quite freely accepted that both an allopathic medicine and a herbal Chinese system of medicine can work together. And I think we are taking a little bit out of the Chinese model of integration. In India, the systems have run parallel. That has been the problem. But we ourselves have shown that a plant called Vijay, which was used by our tribals in Madhya Pradesh, has very good anti-diabetic effect. And this has been done in 10 years of hard work under the strictest scientific rigor.
But isn't still, something like that considered alternative, peripheral, and you go to your doctor and something like diabetes considered serious and dangerous, people tend to opt for a empirically tested, proven drug from Western medicine than something that may or may not work.
Well, this is what we see from a westernized perspective. But if you go to an Ayurvedic practitioner and go to all the people who go first to the Ayurvedic practitioner, their attitude is different. They accept it, they believe in it, and it acts. About 60% of our people in the rural areas who come to a Western trained doctor have already been to an Ayurvedic practitioner or Unani practitioner. That faith is there, and they go there, and as you know, many modern drugs also act by a placebo effect. So does the herbal preparations. The problem is that when you take an allopathic medicine, you know what is in it. But when you take a herbal medicine, the standardization is very weak.
One of your areas of interest is the rational use of drugs, and that is not just the rational use of Western medicine, but drugs across the board. How do you begin to address an issue like that? There are so many formulations. Even if you take a conventional, very popular thing like Chyawanprash, there are a million brands with a million different formulations in the market. What does the poor consumer do?
The poor consumer goes to those 3 or 4 or 5 firms, and I shall not name them, which have a reputation or high reputation for quality control. That is the area which he can be sure of, that they would not probably have unstandardized medicines. That is one thing. And go to a pharmacist who sells it, whom you know. They know which is good, which is fake, which is not so good. And if you develop a relationship with your neighborhood pharmacy, he'll give you the right stuff.
In terms of national policy, and you're in several sort of organizations that are involved with this, what is the government doing? What assurances, what possibilities, what exists in the future for something like this not to happen? And this is in the climate when we keep reading in the press of the vast percentage of drugs that are spurious, even in allopathic, where it's easy to sort of measure it and identify whether it's spurious or not. Difficult it is as it is in say Ayurveda. Look at homeopathy. There's no way of verifying that the homeopathic drug that you buy contains that infinitesimal amount of homeopathy medicine that it's meant to.
The government have asked all Ayurvedic practitioners that if you want us to evaluate your herbal medicine, we are willing to do so and give you a certificate that this is prepared according to standards and this is a standard preparation. They have not come in a big way for this, but here it is something that the government offers. The reason why the government is also offering is because our exports of herbals is suffering. What you have said is said also by people in the Middle East and USA, that your herbal preparations are not standardized. So a big effort is needed for standardization of these plants. I agree with you, not enough is being done, but India is a very big country. Our manufacturers are not controlled. I don't think we even know how many are doing it, and it is a vast problem.
You're watching a conversation with Professor Ranjit Roy Chaudhury. We'll be right back after a short break. Don't go away. Welcome back to a continuing conversation with Professor Ranjit Roy Chaudhury. What is the philosophical basis for alternative medicine in the sense, and how does it differ from the other alternative? In a sense, they're both alternatives.
Well, alternative medicine, Ayurveda, Unani, maybe even the Buddhist system of medicine was also come. They deal and try to restore balance. They believe that disease is caused by imbalance, whether it is yang and yin or others, and that these drugs that they have will bring back the balance. Allopathy, on the other hand, is a reductionist science. They try and find out the cause of every disease and find a cure for it. The result is that allopathy really does not have cures for long-term chronic diseases like diabetes and arthritis and bronchial asthma, and many people today go for alternative medicine for these conditions.
When would you, as someone who has studied so much of this and been involved in it, when would you sort of choose to go to alternative medicine, and when would you choose to go to allopathy. Ultimately, it's a question of if you have the time and you have the patience and it doesn't seem terribly urgent and terribly serious, and then you go into alternative medicine, or you go into alternative medicine when mainstream allopathic medicine has failed, and now doctor gives up and you say, well, let me try this, let me try it, and the operative word is try it. So what kind of choices would you make personally if you were ill?
Well, I think if I were ill, and I've been brought up in a mindset that is rather rigid, in spite of my research, I would stick to the allopathic system of medicine because I get standardized medicines, and I know there is some evidence which shows efficacy.
So even would that be for the entire range of diseases that come up for you, only if you were having a heart attack and of course you want to go for emergency care, or would it be, is there a dividing line? I find it difficult to believe that someone who's sort of this proponent for alternative medicine is saying that. Where is the line for you?
Well, for example, if I had a sore throat today and couldn't speak, I wouldn't take allopathic medicine. I'd take some dhania and put it in hot water, reduce the water to 1/3, and I would be just sipping it. I believe in that. Similarly, if I had some gastrointestinal disturbances, I may take some ajwain. So I agree with you. In simple things, I would take Ayurvedic medicines.
Looking at sort of the other interests, rational use of drugs that you're, again, there is this popular perception that with the increasing privatization of medicine, that while medicine is quality Medicare is available for those who can afford it, it also leads to the indiscriminate use, not just of drugs, but of investigative procedures and methods. What protection, what judgment, what is the thumb rule that a victim of this, a patient, can begin to use?
There are two things. The consumer protection is the answer, because doctors will continue prescribing the latest medicines, the most expensive medicines, because they have pressure from pharmaceutical houses, and also they like to be on the borderline. Information to the public participation in programs of knowledge about medicines would be the answer, and this is the answer that many countries it's already being seen. You ask your doctor, the doctor, why am I being given this medicine when there is a leaflet or pamphlet showing that the other medicine is as good and 1/5 the cost? It has to come through consumer belief, faith.
But ordinarily, isn't sort of, a patient feels so vulnerable, particularly if it's a serious disease, that there's this great reluctance to challenge or question the doctor. You just surrender.
Well, the other side of it is that, of course, the government has a big responsibility of not allowing unnecessary, expensive drugs into the country, because whenever you register a new drug, we should look at the need clause. Is it needed? Is it less expensive? Is it less toxic? Then have a new drug. We don't have that yet. I haven't been able to get the government to accept that yet. They only look at effectiveness and lack of side effects and introduce new medicines. So that would be the other side. Bangladesh, after all, removed 119 irrational combinations overnight. But that was a dictatorship, as you know.
You write frequently in the press about the value of traditional medicine and refer to specific drugs and experiments and what have you. The press is full of accounts every other day, every day really, of studies that have proved something and have disproved something else. And what is a reader, stroke patient, stroke consumer, to make of all this flood of information related to health that he's inundated with?
Well, the reader has to be very perceptive. Researchers, like myself, have a tendency to rush to the press at the first sign of some effective new discovery. Very often it does not turn out to be a new medicine. So that is the first thing. The second thing is that when there is advertising behind it, one has to be very careful about it. I agree with you, the enormous amount of health literature coming out is very confusing, and the ordinary reader gets a lot of information, but how much that information is of help to him or her in daily life is very doubtful.
You're also president of the Delhi Medical Council,
Yes.
and that's looking at sort of doctors' ethics and a whole range of issues associated with the medical profession. You've had a long innings in medicine. In what ways do you feel that the practice of medicine has changed? I don't mean just sort of the new technologies available, the new quality of drugs available, the variety of drugs available, but in more subtle ways. And what can institutions and systems and structures, such as those that you serve and work for, do to make a difference?
Well, let me say, we set up the Delhi Medical Council, and I have been president for the last 5.5 years, but I did hand over last month. I think there has been a very visible change in the relationship between the patient and the doctor. The patient no more looks on the doctor as someone who is semi-god. He has a perception that the doctor may be exploiting him, may be keeping him longer in hospital than necessary, may be giving him medicines more expensive than needed. This is a change which is very sad. On the other hand, doctors too have become more mercenary and less interested in the human aspect of health, disease and curing. There is no question about it. In the Delhi Medical Council, we had to take action. We removed about 6 or 8 doctors from practicing. We fined doctors. We also helped them when they were in charge. But this can only be brought about by a change of heart. I don't think the danda is the answer, really.
You're watching a conversation with Dr. Ranjit Roy Chaudhury. We'll be right back after a short break. Don't go away. Welcome back to a continuing conversation with Dr. Ranjit Roy Chaudhury. What about your personal journey as a doctor from the time you were a doctoral student at Oxford studying Western medicine? Where has it taken you? Where do you think it is leading you?
Well, it took me in rather strange avenues. I started as a pure research worker and a teacher. I went to the Postgraduate Institute of Medical Research at Chandigarh. And then suddenly, one fine day, I went to the World Health Organization, and that meant more management, more support of research all over the world, identification of talent, people who would shine in the next 10, 15 years. And then I came back to teaching, and now I find that I'm chairing a good well thought out commission on macroeconomics and health. It has been a transition from research to clinical trial to management of research.
So when you look at the macroeconomics of health, that sort of suggests pretty much what globalization, free trade is leading to, and that is the commodification of the individual. That you invest in health because it's good economics, not just because it's the human thing to do. You look at cost benefit. I mean, do we need that many specialized heart care centers, or shall we spend it on community medicine? What's going to make good economics? Where does the individual, the human being, figure in this economic framework?
You know what happens if you convince the economists and the policymakers that it is helpful economically to improve the health of the people, the poor people would get a benefit. We have to, otherwise we are not getting the funds that are needed. Our expenditure from the government in health is perhaps one of the lowest in the world, and we have to increase it. We are not able to increase it, and if we can convince them that investing in health care is an integral part of economic development, we would get funds. And then we would use the funds well. Health insurance. We are looking at health insurance for people below the poverty line. So I don't look at it as an either or. I think let's make use of the economic argument, if you say, to help the people to get better health.
So what do you see as the goal of health care at a macroeconomic level? Quality of life, longevity, freedom from disease, to some degree all of these, but ultimately it is a question of priority, of a philosophy of living. Is it worth creating a context where more people are living longer years but are not living as healthy, happy and productive lives? It's a complex matrix when you're looking at large public policy on health. What is your guiding principle?
Well, first, we want every Indian, irrespective of income, to have a certain package of health care which we have defined, irrespective of where they are. Every Indian should have that. Secondly, we believe that this can only be possible through self-participation in some insurance policy. Thirdly, we believe that we are facing a situation where India is going to get older before it gets richer. In other words, our aging population is going to catch up with us before we become very affluent. Therefore, we must change our systems to deal with a large number of old people and diseases which are lifetime diseases, diabetes, hypertension, HIV/AIDS, and the systems have to change. So these are the three broad areas, I would say, looking at it from a commission point of view.
And in terms of your own evolutionary involvement and association with medicine, which you've talked about, and now you're looking at the macroeconomics of health, what is your aspiration for yourself and the contribution you feel that you continue to make and will make, and the kind of impact that you would like to see?
Well, I would like to see in my efforts a system of health insurance where every Indian, at least below the poverty line, has support for primary health care and for some medicines which he needs. This is not so at the moment, and if we can achieve that, I think I would have been very happy to have done that.
And in terms of your own personal philosophy that guides you and motivates you, moving away from sort of the possibility of direct patient care, of feeling and touching a patient, to looking at aspects of policy, the larger picture, as it were, what are the gratifications that you feel you have got from being a medic?
Well, the decisions I get involved in involves millions of people, and that is a gratification. So whenever you take a decision or you look carefully at one thing, it doesn't affect one patient or 10 patients. A new drug released in the country goes to millions of people. A bad drug removed from the armamentarium. So these decisions are much wider, and you get a sense of satisfaction that your field is bigger and wider. So that gives you some sense of satisfaction that you're in the national process. After all, this is a country of 1 billion people, and that is some satisfaction which in a way compensates for what I have lost in research.
There is a perception that not just in medicine but in the formulations of policy that honest professionals such as you are only so influential because it's a context of so many lobbies, of so many influences, of powerful vested interests, because there are huge sums of money that are involved. So how often have you felt frustrated that in terms of your judgment, your beliefs, have they come up against things like this?
Yes, of course, sometimes we believe that something should be done and the bureaucrat or the politician doesn't. But there is a challenge there. The challenge is to get it done in a way that the politician accepts it, and the bureaucrat believes it's his idea. And I look on it as a channel. I've never been frustrated. I've worked with bureaucrats, I've worked with politicians, I've worked with difficult politicians, and we've got on very well. It's a matter of dialogue, talking with them, trying to convince them. I've worked as an advisor to one minister in one government, the new ministry comes, another government, but we've stayed on. So I think it's the attitude that you're not going to give up.
Thank you very much,
Thank
Professor
you.
Chaudhury. That's been great.
Thank you very much.
Thank you very much.
Thank you.